We're going to look at gas exchange and flow volume loop evaluation from exercise testing. Starting with our ABG assessment, to do this we can either use an arterial catheter, which is probably safer, and we can then take serial measurements along with different increments of exercise, or we can do an arterial puncture. Either way, the ABG is going to be the most accurate evaluation of O2 and CO2 as long as it's drawn at the appropriate time. It needs to be drawn within 30 seconds of observation of maximum workload. If you do not draw it soon enough, then you have to repeat the entire process. Pulse oximetry can be used, and this is nice, so you can trend oxygen saturations throughout the entire procedure. Obviously, it's less accurate, and you would need to verify with co-oximetry, because if the person has low hemoglobin, that can contribute to shortness of breath. ABG with exercise is most valuable if it's compared to an ABG at rest. Kind of obvious. Our pH should remain normal until anaerobic threshold is reached, and then it might become slightly acidotic. We covered this in our last video. The arterial to venous content difference, this is the milliliters of oxygen per 100 milliliters of blood. Normal is about 5%, and then with exercise it should be 2.5 to 3 times higher than that. And this is due to the greater amounts of oxygen that are extracted by the actual working muscle tissues. Now, the alveolar arterial oxygen difference normally should be about 10 mmHg, and with exercise it should increase to 20 to 30 mmHg. It's going to change very little until an actual heavy workload is achieved. VD to VT with exercise, again, here is the calculation for that. It's not going to change. And obviously it can be calculated and found a variety of different ways. If you're using a breath-by-breath system to calculate the VD-VT non-invasively by substituting an end-tidal CO2 for the PA CO2. So this assumes that the PETCO and PACO are equal. Normal alveolar ventilation should be about 4 to 7 per minute. So the VD-VT ratio should be about 0.2 to 0.35. It should increase, or the dead space should increase during exercise with an increase in minute ventilation. The overall result of that will be an actual decrease in the VD-VT ratio. Now, if you have an abnormal VD-VT, you're going to see it with an airway obstruction or peripheral vascular disease. And in these conditions, you're going to see the VD-VT remains constant, or it might increase. If a person has pulmonary hypertension or those inappropriate breathing strategies we talked about in our last video, then you're going to see that VD-VT ratio increase. And this means that ventilation is increasing in excess of perfusion. So that is not normal. Here we're going to look at our flow volume loops with exercise, and this allows a clinician to identify the percent of flow limitation. This method may work better to find the increased work of breathing in individuals who do not reach a classic definition of ventilatory limitation, but they do have a substantial component of flow limitation during exercise. And it's monitoring the tidal flow volume loop during exercise can also show dynamic changes in the flow pattern. So here is our tidal flow volume loop here in the red, and then in green is the maximal flow volume loop. So we call this red one the exercise tidal flow volume loop. Okay, tidal volume, again, it's going to go across the horizontal axis. On this end, you're going to have your end expiratory lung volume. On this end, you're going to have your end inspiratory lung volume. And then right here, you see kind of this highlighted in pink area. This is where the exercise tidal volume lines up with the maximum flow volume loop. And we're going to talk about that more here in a minute. Okay. Flow volume loop analysis. This is actually better to see. I should have put it on this slide first. Again, the green is your maximum flow volume loop. This red one is your exercise tidal volume flow volume loop. Your tidal volume for exercise is from the EILV to the ELV, And then we're going to compare the portion of that that lines up with our expiratory limb of our maximal flow volume loop. And that's going to give us some important information here. Okay, back to our end expiratory lung volume. Remember, this should decrease with exercise. However, people with COPD, they have larger than normal end expiratory lung volumes. With expiratory airflow limitation, 25% of the tidal volume at peak exercise workloads. And that's this right here, okay? Where this lines up with your expiratory limb on your maximal flow graph, that is showing you your expiratory airflow limitation, where those two lines meet up. Flow limitation occurs only over the lower lung volumes near the end expiratory lung volume. So you're going to see it on this side of the loop, okay, which is kind of obvious. What is expiratory flow limitation? It's the percent of the tidal volume that meets or exceeds the expiratory boundary of the maximal flow volume loop. So again, here's our maximal flow volume loop, okay, and here's where it's matching it, or if it exceeds it. That's going to show you where there is flow limitation. So normal healthy lungs shouldn't have flow limitation. Somebody with COPD should. That's kind of the synopsis of that. So here's a couple different examples. So this is a normal person exercising. Okay, the black loop is their exercise loop. The blue is their maximal flow volume loop. Someone with flow limitation, it's going to look like this. You can see the scooped out appearance, definitely telling us it's COPD. And then where this black loop overlaps with the blue loop, that is showing us where the flow limitation is occurring. So this person does have flow limitation. This one here actually has inappropriate breathing strategy, and you see it shifting, notice, over to this side over here. Over down here on this one, they have also an inappropriate breathing strategy, but it's a reduced end expiratory lung volume, and it's shifting over to the residual volume. Lastly, this one here is showing an extrathoracic obstruction, which is causing the decreased flows. So let's take a look at an example. So this is the same example we've been working through on our other videos. So this person complained of shortness of breath, which is why the test stopped. She reached 63% of her maximum VO2. So if we start by looking at her blood gases at rest, they look fairly normal. Her PO2 is a little low. O2 sat's a little low, otherwise not bad. When we look at it with exercise, her pH did drop, but not to an acidotic level. I mean, we're still in the normal range. And CO2 did increase a little bit, but not crazy. We also see that our O2 dropped just a little bit. Her AA gradient should be between the 20 and 30 range, and it is. And remember, that's not going to change until there's excessively heavy workloads, and so we essentially remain the same. So this person did not get a heavy workload. The VDVT starts at about 60% and then increases up to about decreases down to about 52%. So overall, these results show consistency with ventilatory limitation, which again, with the patient complaining of shortness of breath, to stop the test, that all correlates together.